Pulmonary for critical care. So as our first lecture, we're doing all of what RTs learn, all right? So we still have to know what the RTs know. We don't have to know in super detail because the whole purpose of the RT field is to know every single model and every single unique thing about all different devices and how to manipulate all those things, in addition to what we're learning here. And we're going to be applying most of these things. I don't just give you things for you just like, oh, that's cool. Usually it's for some application clinically, okay? So we'll be doing, for instance, looking at pH and ABGs up here. We're looking at AA gradients a little bit. We have a section on AA gradients. We have a thing on arterial content of oxygen, how much oxygen you're delivering to the tissues, and it depends on hemoglobin, cardiac output, other things that are why my patient not oxygenating well, right? And we'll talk about vents and then on our next lecture. Today we won't touch on vents too much. Towards the end we'll talk about ABGs and adjusting vents, but mostly all about vents and pressure and resistance and peak pressures, plateau pressures. That'll all be the next lecture, okay? And weaning, that's actually, I think it's the third lecture for pulmonary, where we talk about how do you get a patient off the vent? Are they good to come off the vent, right? One of the key numbers there is RSBI, which is this guy right here, okay? Pulmonary hypertension, we got a little slide on pulmonary hypertension, but it's up and coming. There's a lot of people with pulmonary hypertension nowadays, and we have a slide on that. All right, usually obesity, long COVID, pulmonary fibrosis, all these things lead to pulmonary hypertension, which is important to recognize, okay? So today we're talking about ABGs towards the end, all right? So we'll be doing some ABGs. We'll be doing a lot of pulmonary hemodynamics, all right? So a lot of pulmonary numbers. We're going to talk about O2 a lot, right? How about, if the oxygen is low, what is it? Why is it low? What did it come from? Okay, is there something we can fix? Usually, giving oxygen will fix most situations. Some other situations you might have to give like thrombolytics for a pulmonary embolus, right? Otherwise, or antibiotics for pneumonia. So, but oxygen is usually the first step, and we'll talk about the reasons for that. We'll talk about CO2 just briefly. Next lecture, we'll talk about end-tidal CO2, where we're really going to get into CO2 and tracking it and looking at waveforms. Okay, and then what else are we doing today? I think we'll talk about O2 CO2 movement, like the O2 hemoglobin dissociation curve, everybody's favorite, right? And then we'll talk about CO2 as far as its effect on a curve and how it relates. Okay, so that's kind of an overview of what we're talking about. Okay, so VQ, so ventilation perfusion. All right, so we have to ventilate a patient. They have to get oxygen, right? And ventilation is the movement of air in and out. Air in is my name, by the way, right? So air in and air out is what ventilation is. All right, so ventilation, if we could bring oxygen into the patient right here, we inhale it, right? We inhale room air oxygen. And how much oxygen is that? What's the percentage of oxygen? 21%, right? So that's a percentage of our atmospheric pressure. So 760 is sea level, right? Venice Beach, San Diego Beach, Carpinteria Beach, that's 760, right? And down there, you take 21% of it, right? 21% of 760 is a certain pressure of oxygen, and that's going to get delivered to our lungs. If we're on Mount Everest, which has a pressure of like 200, right? 20% of 200 is a lot less than 20% of 760. That's why it's difficult to breathe on Mount Everest, right? So they usually acclimate after a while, a week or two to get their bloodstream to make some more RBCs and whatnot. But yeah, inhaled gases, all right? So usually we're inhaling 21% oxygen, or we can deliver more oxygen. And our next lecture talks about O2 modalities, whether you deliver it with a cannula or a mask or a BiPAP or a vapotherm or a ventilator, right? All those things are delivering oxygen to the patient, right? And then you exhale CO2. So you inhale O2 and exhale CO2, right? And we can measure how much CO2 comes out, right, on our end-tidal CO2, which again is our next lecture. But right now we're worried about what's going on in the middle here, what's happening right here at the alveoli, right? The O2 comes in and it needs to get into the bloodstream somehow, and sometimes there's problems there, right? Sometimes there's problems getting oxygen across through to the alveoli in the first place. Someone has an upper airway obstruction, that's going to make it difficult, right? Someone has mucus plugging, that's going to make it difficult as well. Someone has diseased lungs like COPD, that can make it difficult to get O2 down the lungs, or maybe they have difficulty getting CO2 out of the lungs, right? Because CO2 is also dropped off by the blood, right? The blood is going to be, there's concentration gradients, right? If everything in the universe goes high to low. There's nothing that doesn't, right? Everything goes high to low pressure, high to low oxygen, CO2, high to low water, where there's a lot of water, that'll go to where there's little water, right? That's called osmolarity. Otherwise, we are diffusing oxygen and CO2 to where it's higher or lower, right? And we'll talk about ABGs and what the PO2 is on the arterial side versus what the PO2 is in the lungs, right? Things are going to be moving from high to low, okay? So hopefully you're bringing oxygen into the alveolus, and that's oxygen is higher, right, than the bloodstream, and it's going to then deposit the O2 into the bloodstream, right? And usually it's about 100. I should probably put that in my green color, or I should probably use blue, shouldn't I have? So there's blue, right? So here's our oxygen going from the alveolus into the capillaries, right? And the alveoli usually have about 100, and the capillaries, right? This is blood is coming from the where? From the right ventricle, right? The right ventricle is pumping blood into the pulmonary arteries, and that blood is oxygenated or deoxygenated. It's deoxygenated blood, right? So the PO2 is obviously less, right? It's going to pick up oxygen. It's going to return to the where? Left atrium, right? So left atrium is going to receive oxygenated blood, and then of course we're going to pump that guy out to the rest of the body. So the whole purpose of the lungs is to pick up that oxygen, right? And we need to ventilate. We need to get an adequate amount of oxygen into our lungs at all. And then we have to be able to get rid of CO2 as well, all right? But really we're going to be focused on the oxygen story. And the oxygen story to bring oxygen in versus getting oxygen to the body is your VQ, right? So if our perfusion over here is no good, right? Let's put this in dark purple, right? So maybe I'm having RV failure, or I have pulmonary hypertension, which is making it difficult for my RV to unload, right, blood to the lungs. Well, I'm not going to get a lot of good perfusion there. That's not as common as the most common blockage here, right? When I have a blockage in my pulmonary arteries, what's that called? That's called a PE, right? If I have a pulmonary embolism, that's going to be a drop in what? Ventilation or perfusion? It's a drop in perfusion. So it's a drop in the Q, all right? And we'll use some of our math skills in the next slide where we talk about you can kind of use a eyeball of what or an estimation of what the VQ is, okay? So PE can be in the way, but more commonly it's going to be something in the way over here, right? Something's in the way of the alveolus. Maybe the alveolus is getting filled up with fluid, or filled up with pus, or filled up with fibrotic tissue, right? So like pulmonary fibrosis, that's where it's usually genetic, or it could be like exposure to mesothelioma, right? You hear on 2 a.m. in the morning, right? So those things cause pulmonary fibrosis and makes it so it's difficult for alveolus to unload oxygen. It literally gets fibrotic, right? And it's not easy for oxygen to go through the alveolus to the capillaries, but then you put all this fibrotic scar tissue in front of it, it's going to make it a lot more difficult, right? But more common than that would be just something like a straight up pneumonia, right? We got a little pneumonia going on here, right? And the pneumonia can be in the alveolus itself, right? Those are infiltrates that you see on X-ray, or you can see an effusion, which is those infiltrates that are outside the alveolus, right? So an effusion is more watery infiltrates, whereas and it's pus too, but pneumonia is more, those infiltrates inside the alveolus, those are going to build up, and that's pus that's building up, right? And that's going to be difficult for the oxygen to go through the pus into the bloodstream, right? So that's a deficit in ventilation or perfusion if you have pus in your alveolus. Yes, that's a deficit in ventilation, okay? And yes, straight up just not breathing is an issue too, right? If you take too many sedatives, that's a decrease in your ventilation also, right? But sometimes we can recognize that, we can give reversals and such, but really we're looking at the more disease processes and see why are they the way they are? Why is their oxygen so low? Okay? So VQ. So V is ventilation. What does Q stand for? Perfusion, but it's French, right? So it's French for quotient, but quotient in French, like quotient, I don't know. But so it's ventilation or quotient or portion of blood. It's the portion or quotient of blood that's being delivered. So it's our Q, okay? So how much perfusion are we getting to the lungs in the first place, right? Sometimes we, on the ventilator, will increase the PEEP so much, right? People get higher and higher and higher, and the PEEP is to open up more alveoli, and it's going to start compressing the arteries. So too much PEEP can lead to a drop in perfusion, okay? So that can drop your blood pressure, but also it can also impair the flow of blood to the lungs and lead to hypoxia in of itself, okay? So we'll talk about the two differences there, and we'll talk about what are called shunts, okay? So a shunt versus a dead space, right? So a shunt is where, you know, the blood is arriving to the lungs and it's ready for business. It's ready to pick up some oxygen and drop off some CO2, right? So it's coming along, and it's there, and it's like, well, no one's home, right? It's full of pus, right? Or it's all fibrotic, or they're not breathing, right? There's no oxygen or CO2 for it to, you know, to exchange with, and then it's just going to go right back on its merry way back to the left atrium, right? Did it pick up oxygen? No. So and all it did was shunt. It just went from what, right to left, right? From the right side of the heart to the left side of the heart with no pickup of oxygen. So obviously they're going to be hypoxic. And so we're figuring out why are they hypoxic. And it can be due to a really bad pneumonia or really bad ARDS, for instance. Okay, so shunt is important. That's like, there's like yeah, you can't have you're not going to have 100% of a shunt. It's usually it's like a scale 1 to 10. You either have a little bit of shunt or a lot of shunt. If they have like 100% shunt, they're not living, right? And on the flip side, we have what's called dead space. And dead space is where you're just putting air into a space and it doesn't do anything, and then it just comes right back out. So they might be ventilating just fine, right? They're breathing in and out, O2 comes in, CO2 comes out, but it didn't pick up anything because there was a PE, for instance, right? So they came in, and that part of the lung, that alveolus, was not getting capillary blood flow because there was a pulmonary embolism in the way, right? And therefore it just, so, nothing to do here, and it just comes right back out. Okay, so that's called a dead space, where there is just no exchange of oxygen and CO2. And obviously it's a scale 1 to 10. If it's a 10 and there's absolutely no alveoli participating, you're probably not in the ICU. You're probably dead, unfortunately, right? But if you are, you know, there's some scale, some continuum in between. That's where we can figure out what's going on and say, oh shoot, you have bronchospasm. Or it's not bronchospasm. Sorry, you have a pulmonary embolism, or you have really, really bad pulmonary hypertension. Your right ventricle has failed, right? So that's going to make it so that, yeah, it's not delivering blood adequately to the lungs, and those areas of the lungs are not going to be able to participate in O2 CO2 exchange, and then you're going to have just a dead space. Okay. So overview. So normal VQ is 0.8. Okay. So if you think of 0.8, that's 8/10, right? So you can think of 8 over 10, or 8 is our ventilation, 10 is our perfusion. We have a lot more perfusion than ventilation, right? There's a lot more blood in your lungs right now, and normally, than there is air, okay? So your blood's ready to go. It's ready to pick up what? What does blood pick up when it goes to the lungs? Picks up oxygen, right? So the oxygen is going to get picked up in the lungs, right? And also it's important for the blood to drop off CO2. Okay, and again, that's all by concentration gradients, right? So it's going to make sure that it's going to be, we got to make sure we're making sure, but those gradients can be destroyed, but usually it's a factor of, you know, are we getting this blood to the lungs or not? Okay, so we do have what's called end-tidal CO2, so we can see the CO2 start actually climbing up, right? If they are making more CO2, or their CO2 is not getting out as much as it should, the CO2 is going to build up inside their bloodstream, and then you can measure how much CO2 is coming out of their mouth, right? And that means there are many different things it could mean, and we'll talk about end-tidal CO2 in our next lecture. But we want to make sure we have an adequate amount of oxygen delivered to our blood, to our body, right? And yeah, so this is PO2 should be 100. That's an error, sorry. So that should be 100 there. Okay, so normal PO2 in the lungs or in the alveoli are 100, and we got a venous oxygen of 40. So 40 to 100. Well, shoot, that means that means it's going to drop off all of its oxygen onto that RBC, right? It goes from high to low. Same thing, your body picked up CO2 from the tissues, and it's going to bring it to the lungs to hopefully drop it off. The CO2 is going to be around 46 to 50 or so, and it's going to drop it off at the alveolus. Okay, I was talking about CO2, so end-tidal CO2 about 35 to 45, which is much less than 46, right? So it's going to go from high to low. Okay, so yeah, so V is ventilation, all right? So air going into the alveoli, and Q being our perfusion or our quotient of blood, right? That's the blood that's arriving at the alveoli. So that blood may not arrive at the alveoli because of other disease processes. So we call this a VQ mismatch when there is a abnormal V or an abnormal Q, and that's the most common cause of hypoxia. There are other reasons, but if you're again on Mount Everest, you're not inhaling enough oxygen, so that's not really a problem with my lungs, right? My lungs are working just fine. It's just because I'm not inhaling enough oxygen, right? Or I'm suffocating because my nurse put me on a 4-liter simple mask. That's called iatrogenic suffocation, right? What does iatrogenic mean? That means oops, right? It's Greek for oops. It means I didn't mean to, right? So a simple mask is meant to be at 6 liters or more. Otherwise, there's not going to be enough oxygen delivered to that mask, and they're going to start exhaling CO2, and they're going to suffocate, right? So VQ mismatch is the most common cause, though, of hypoxia. All right. Normally, again, we have more perfusion than ventilation. There are 3 different zones of the lungs, right? And this comes into play when you talk about pulmonary artery catheters, right? So you have a PA catheter over here. When we talk about hemodynamics in cardiac, that's where you look at your, you want to make sure your catheter is optimally placed. You want it optimally placed in the area that's not going to be affected by your ventilation or your lung volumes. So you want an area that's just where there is blood the most, right? The most blood is down at the base of the lungs. The reason for that is gravity, right? So there's more gravity going from top to bottom. So you're going to have more pressure more blood pressure in the bottom of the lungs. There's 3 zones of the lungs. Okay, so here's our RV over here pumping blood to our lungs, right? And then it returns that blood to the left atrium, right? So that's the normal cycle. And again, there are different zones of the lungs where they have different amounts of air versus blood. So yeah, the top of the lungs, they're going to have a lot more air than blood, just simply because of gravity, right? So more air is more what? V or more Q? More V or ventilation, right? There's a lot more air that can get into the top of the lungs versus the bottom of the lungs, right? So more V, instead of being 8, let's make it 16, right? So if you know your fractions, people don't like math, and people don't like fractions more, so I'm sorry. So 16 over 4, right, is 4, right? So my VQ is 4. I have an increased VQ there, right? Versus normal VQ being 0.8, or 8 divided by 10, right? So the reason how to get 4, I didn't mention it, but I have a decreased perfusion there. Normal's 10, it's going to be less than that. I just chose nice numbers that are easy to do mental math with, okay? So we have decreased perfusion to the top of the lungs, but increased ventilation. So we have what, a high or low VQ up there? High VQ. Yeah, at the top of the lungs, you have a high VQ because there's more ventilation than perfusion. So we just take our 8 and 10 normally, and let's crank up the 8 to 16. Let's crank down the 10 to, let's say, 4, right? So that's kind of how we kind of visualize what's going on, okay? So then what else? So yeah, there are 3 zones. Again, air is lighter than blood, so that's why there's more air up top versus blood at the bottom, okay? And VQ mismatches do exist in each zone, and basically all of this blood that's being delivered to the lungs, sometimes there can be a pneumonia. That's at the base of the lungs, for instance. And then, yes, you deliver great oxygen up top, but there's less blood at top, right? So really it's an average of all the blood throughout all the lungs that's being delivered back to the left atrium, right? So there's certain weighted averages here about all the blood that's being delivered and actually how much oxygen it's actually going to pick up, okay? So that's how we look at VQ. So now that's the normal. Now we're going to tip the scales to what's abnormal. Okay, so again, if you have to guess if someone has what kind of VQ mismatch someone has, basically 9.5 times out of 10, it's low, right? Low VQ. So if I have low VQ, that means that's less than or greater than 0.8. It's less than 0.8, right? So VQ is 0.8 normal, and we said up here at the top of the lungs that was a high VQ, which is 4, right? This equals 4 right here. So more times than not, it's because of a lung issue why our VQ mismatch is in play, right? Or is affected. So if I have a pneumonia, for instance, I have a pneumonia all down here, right? Is that an increase or decrease in my V? It's a decrease in V. So if it was 8 over 10, And now that's to give me a number less than 8. That's easily do mental math with. Okay, numbers aren't hard. Let's just a number less than 8.
Oh, 4.
4. All right, so instead of 8/10, it's 4/10, right? Because I have a decrease in amount of air delivery to my lungs because there's a pneumonia, there's an effusion, there was a pneumothorax, there was ARDS, there was, a blunt trauma, there was hemothorax, chylothorax, there's all kinds of things happening in the lungs. That's a reduction in my V, right? So instead of 8, it's 4. It could be 1, right? If it's 0, that's 0 divided by 10 is 0, but that's not usually sustainable. Right, but yeah, so it's went from 8 to 4, 0.8 versus 0.4, right? 8/10 divided by 4/10, or compared to 4/10, that's why we have a low VQ, right? So if you have to guess, it's a low VQ, right? The only time really it's a high VQ is when you have like a PE, right? That's usually the most common reason for a high VQ. Okay, so we're looking for pathology either in the lungs or pathology in the delivery of blood to the lungs, right? Blood being our Q, and our lungs having issues, our V, our ventilation. Okay, and then if there's issues there, or if there's no issues, it returns to the heart and all's good. But if there's an issue in the lungs, then we got to figure out where it's coming from. Okay. So VQ scan. So there's something called a VQ scan that we can send our patients to, right? So VQ scan is not that great, all right? If you look at a actual VQ scan, this is literally what you're looking at, right? And they find a guy, hopefully he has really thick glasses, so you can look at that and you can say, yeah, the ventilation a little bit less over there, and VQ, it's little issues over here. You can see decreased perfusion over there, ventilation might be okay over there. It's very, very subjective, right? Sometimes it's really super obvious when there's like absolutely nothing perfusing, right? So they see little perfusion defects here when all the lungs should be getting perfusion, all right? This is normal up here up top, and this is abnormal down here, right? So yeah, so VQ scan looks, what they do, they give radioactive dye to the patient, and it's in 2 phases. They give the dye for them to ventilate, and they take a snapshot of all that dye inside the lungs, and they say, oh, that's how good your ventilation is. And then they take all the dye, they take other dye, and they give it through the IV, and they take another snapshot to see the perfusion in the lungs, right? They see all the blood flow in the lungs, and they compare it, right? They can overlap it maybe, and they can kind of maybe tell where it's at, so it's not incredibly accurate, right? Usually it's like 480p or like a CRT TV back from the 90s, right? So it's not that clear. Versus where you have what's called a CT angio, right? A CT, computerized tomography, with angiography, where they're injecting dye again, but they can actually look and they can zoom in with it's like almost like 4K resolution. They can zoom all the way in. They can see, oh look, there's a little area of lack of flow in this little vessel right here. And they can tell exactly which vessel, and they can even, if it's a big vessel, they can even go to the cath lab and do a thrombectomy where they take out a PE, for instance, right? So yeah, again, 2 parts, the V and the Q part, right? The V, they inhale the dye, right? And then we're looking at how good their ventilation is, and whereas Q, they're looking at how good the perfusion is, right? They receive an IV radioisotope, okay? It goes in the blood, and it goes to the lungs, and we take a little snapshot down in the radiology lab, or the nuke med lab, and that's where they can see how it is, right? There are some fringe cases where you might need a VQ scan. An ICU patient, probably not going to go down there because they have to inhale it. You can't give it through the ventilator, right? So they have to be in the ICU, and if they're in the ICU and that sick, they probably can't lay flat for this study in the first place. But usually, if your patient has risk factors for a PE or suspecting PE, we're going to send them down to where instead of a VQ? A CTA, right? That's not bright enough. There we go. All right, so a CT angio of the chest. There are CT angios of the head and neck. There's CT angios of the belly. There's CT angio, or they call them runoffs, of the legs. But we do CT angio. Usually when we say CTA, you're thinking of a PE. Because when you say PE, you're thinking of pulmonary embolus, not pleural effusion, right? So PE is usually the most worst case scenario that we're trying to think about. Okay, and again, going back to like who can't qualify for CT pulmonary angio. So there's a dye allergy, right? They're allergic to something. What might they be allergic to in real life outside the hospital? Which is real life, right? So that's what would they be allergic to? Where you say, oh shoot, they probably might not be a candidate for this study. shellfish, right? So if they are not selfish, but if they are shellfish allergic, then they are a risk for having an allergic reaction, and they probably are not a good candidate for this, definitely for the CT angio. The radioisotope, there might be some cross sensitivity. We can give Benadryl, we can give steroids and such to a mucomist to kind of clear it out if we need to. But for the most part, a CT pulmonary angio, it can't be done when they are allergic to shellfish, right? So when they're allergic, then they can't usually go for CTA, okay? So contrast-induced nephropathy risk, right? When there's a risk for nephropathy, what does nephropathy tell you? There's a pathy of the what? Of the nephros, right? So that means they have kidney dysfunction or renal insufficiency or acute kidney injury, right? Usually creatinine greater than 1.5, I think is our cutoff. That's usually where they say, well, maybe it's not a good idea to get a CT pulmonary angio done. We can do something that is a little less, not invasive, but less stress on the kidney. And just so you know, conscious-induced nephropathy is a complete myth. There's no absolute science about it at all, right? If that back in the 50s and 60s, when they used iodine, these dyes that did cause kidney damage, yes, but we don't use dyes that are more than 60 years old, and here at least, right? That's why they were slowly getting towards it. About 2 years ago, we had to have everybody sign consent for CT angios and such, and now they took that away. So and hopefully some of the people will phase out the idea that it actually causes kidney damage, because it does not, right? So there's, but that's still something that's like on paper, and then the CT people, they're going to go through a checklist like, oh, creatinine's 2.2, can't do it. But so can I give vancomycin? Go for it, all for it, right? Vancomycin, perfectly fine, right? Vancomycin has a huge risk of nephrotoxicity compared to, or not even compared to, because CIN or conscious-induced nephropathy has no effect on kidney dysfunction, okay? And radiation exposure, all right? So they have a risk because this is nuclear med, and nuclear med sounds a little bit ominous, right? Where am I going today? You're going to nuclear med. What does that mean, right? So some people are at risk for radiation exposures, such as young female patients who have breast tissue or are pregnant. They can have a risk of complications, a possible increased radiation exposure. Okay, so why would you get a VQ scan, or why would you even get a CTA in the first place? Why would you suggest it to the provider? Would you say, hey, do you think we should maybe get a CT angio? You probably would not suggest a VQ scan again for your ICU patient. You probably suggest the CT angio. All right, and that's what it's called, as Wells criteria. So it's just it's kind of eyeball of what some kind of risk factors you would look at. You don't have to know which one's which. You can look it up and say, hey, I have this, and this, and if it's greater than 6, really pretty much you need to get a scan. It's not good practice to not get one. But if they have swelling of an extremity, that's a problem, right? That's a risk of a DVT, and now they're short of breath. That's a problem, right? And basically what happened when you have a DVT is it broke loose, right? So which one's an embolus? The one in the arm or one in the veins, or in the pulmonary veins or pulmonary arteries? Which one's the embolus? No. DVT, the T stands for thrombus, right? And so PE, or pulmonary embolus, is a clot that has dislodged and is traveling, right? So a clot in motion is called an embolus. A clot in place or in situ, right? That is called a thrombus, right? So a deep vein thrombosis, they have a diagnosis of DVT, and now they have shortness of breath. Well, shoot, I should probably get a scan to make sure they don't have any kind of lung issues, right? Do a CTA to see if they have a pulmonary embolism, right? Because they might have to be on what kind of medications? What medication do you give to someone with a PE? Clot busters and clot preventers, right? So usually we start, heparin, right? We start anticoagulants. That's usually what we're going to be starting. Usually we start what are called DOACs, right? They used to call NOACs, novel oral anticoagulants, but their DOACs are direct oral anticoagulants, like your 10As. You might have heard of Eliquis, right? So these guys are Xarelto. So these guys are direct oral anticoagulants. They're better than heparin, but sometimes you'll see your patient on a heparin drip in the meantime, and then we'll transition them to a DOAC, right? They're transitioning them to warfarin. That was again 20 years ago. We should not be doing warfarin. There's only like 1 or 2 reasons for warfarin nowadays, right? But yes, anticoagulants, and also you can give TPA, right? You give TPAs or strokes, right? You can also give TPA for a PE, right? They have a huge embolism in their lungs and they're really, really short of breath, And definitely if their blood pressure is low, because if you don't have, a huge blockage from your right ventricle, that can lower your blood pressure, right? So that's a problem that can happen, and so in those cases we might even consider giving TPA, right, to bust the clot altogether, right? If not, then definitely they should be probably on anticoagulation. Okay, so again, if they have a clinical signs of a DVT, 3 points, right? They have a heart rate greater than 100, right? That's usually because of hypoxia, right? When you have hypoxia, that stimulates what? What gets stimulated when you have hypoxia? Yes, your SNS, right? Your sympathetic nervous system will get triggered when you have low oxygen states, right? And then you have what else? You have immobilization for 3 or more days. That's the high risk, and they have shortness of breath. That's probably, well, what else could it be? Yeah, it could be pneumonia, it could be atelectasis, but it only gets you like 1.5 points if you notice, but it's going to get you up to more than 6. And then we have a lab test. What lab test can we do to see if someone might have clot fragments in their body? Yeah, a D-dimer, right? So a D-dimer right here. So I got D-dimer positive. I thought it was, I saw here, I might have lost it, right? But yeah, D-dimer. If you have a D-dimer that's positive, right, that is, it could be telling you that you might have a PE, right? D-dimers are, or what are called FDPs, fibrin degradation products, right? FDP is another name for it. That's just clot breakdown, right? So if I have a clot that dislodges and goes to my lungs, there's clot that was being broken down, right? And there's clot fragments in my bloodstream, and I can measure that. And if that D-dimer is positive, that might be a PE, right? But the big asterisk there is that what else makes clots break down is sepsis. So someone's here for pneumonia, right? You can't say, oh, they could have a PE. They could, but the D-dimer is not going to be the test to tell you. And again, if you have to do surgery, right, they're probably clotting and breaking down stuff too. Post-op patients, that's not going to be a good indicator. But post-op patients are high risk for PE, right? They're bedbound, all these things, right? They have malignancy. Malignancy is a strong thrombotic situation, right, where you make a lot of clots when you have cancer. So that's a high risk for not only DVTs, but also PEs, okay? So that's what you're looking at for when would you get a VQ scan versus when would you get a CT angio. Basically, our ICU patients are getting CT angios. And again, this is a 4K version to see exactly where the PE is, right? So extremes of VQ mismatches. So PE is which VQ mismatch, a shunt or a dead space?
Dead space.
Dead space, right? So dead space means there's a lack of blood flow to the lungs, right? So the air goes in, it hits a space of dead air, and it just leaves, right? It can't interact with the blood in a meaningful manner. If it's not interacting at all, that's a problem, right? But definitely we have a reduction in our blood flow, right? We have no blood flow right here, right? Because I got a PE brewing right there. I got a huge clot in the way, and there's no what? There's decrease in Q or V? Decrease in perfusion to that particular alveolus, or it could be a segment of the lung, or it could be both lungs, right? You've heard of saddle emboli. Those are the worst kind of PEs, right? Versus like a subsegmental PE, that's just one little segment of the lungs, right? But that little segment of the lungs that does not get perfusion because of PE, that's going to be dead space, right? The air comes in, right? Oops, it did change this guy here, right? The air comes in to here and it just leaves right back out, right? It's a dead space. There's no ventilation perfusion that happens there. Oxygen does not get dropped off, right? And if this was like 40% of the lungs, and this was the other 60%, 40% of the lungs don't get oxygen, that can be a problem. It leads to what, hypoxia or hypercapnia?
Hypercapnia.
Hypoxia. So hypoxia is a reduction in oxygen. Hypercapnia is a buildup of CO2. When you have a PE, you're just like, well, CO2 can't get dropped off either. But you have your other lung that can help, but really this is hypoxia going to be the first thing that you're going to see, right? And we actually can measure how much end-tidal CO2 is being exhaled, right? And if I have no CO2 being delivered there, the CO2 is going to be reduced up here, right? The end-tidal CO2 will be reduced. Yeah, you will have a mild increase in CO2, but they're going to probably be breathing faster, right? Because of the SNS, right? The SNS is going to make you're tachycardic and tachypnic. You're going to compensate and breathe a little faster to try to get rid of, or try to get oxygen into your blood, but also you're going to be blowing off a lot more CO2, right? So like yes, the CO2 is going to go up a little bit and the O2 is going to go down a little bit, but what's ultimately going to happen is the oxygen is going to get a lot less, right? Because you can't fix this, but you can breathe a little faster to compensate, okay? So VQ, right? I have an absence of perfusion, right? Absence of Q, right? You can't divide by 0, unfortunately. That's a math rule, right? So we're just going to say 1, right? So we have 8 over 1 instead of 8 over, instead of 8 over what? What's normal? Normal Q is 10, right? 0.8. So if we have a drop from 10 all the way down to 1, right? So that we're going to have a dead space, right? 8 over 1 is a increased, or is more than 0.8, or is it less than 0.8? 8 divided by 1. Yeah, 8 divided by 1 is 8, right? And 8 is greater than 0.8. So that's a high VQ or low VQ? That's a high VQ, right? And again, everything is usually low VQ, but PE is usually our one we're worried about the most, right? Inhaled air does not participate with any kind of gas exchange at all, right? It's closed for business over here in the alveoli that are not getting blood flow, okay? There is such thing as anatomical dead space, right? Anatomical dead space is, we're not talking about the lung units that have dead space because of a PE or something. We have up here in our bronchus here, right? Up here in our trachea. Yeah, you get blood supply to your trachea, right? If you ever witnessed tracheostomy or watched a movie where they do like cricothyrotomies and such, yeah, there's a lot of blood there. But does that blood actually participate in O2, CO2 exchange? No, that happens all the way down at the alveoli, right? Sometimes at the little terminal bronchioles over here. So the little bronchioles there, they'll sometimes happen, but all your O2, CO2 exchange happens over here, right? At the terminal alveolus and the terminal bronchioles. But there is such thing as dead space up top where air does come into the contact with the sides of the trachea and the sides of the bronchus, but there's no O2, CO2 exchange. That's anatomical dead space, right? The trachea, the bronchus, and sometimes you have non-functioning alveoli that are not ready for prime time just yet. So that's your anatomical dead space. And usually it's about 1 pound per ml. So if you have a 150-pound patient, they have about 150 mLs of dead space, right? This is why your patient's on a ventilator, you never see a tidal volume of 150, right? Because you have to get past the 150 cc's of dead space first, right? And then that air can make its way down into the actual lower lungs, okay? And then there's alveolar dead space. That's where the perfusion is impaired because of what we're talking about now, a PE, right? And that's where we can get give TPA to bust the clot and hopefully improve the VQ, right? Or thrombectomy, you can go in there and suck out the clot, right? So here we have a lot of clot happening right here, right? Big clot there, so we're going to go into the arteries and we're going to pull out, or part of the pulmonary vasculature. We're going to go into on the right side and we're going to pull out that clot, right? And hopefully improve this lack of perfusion or this dead space over here, right? That's dead space, and PEs, which are the most common reason for a lack of perfusion in the lungs, right? And then we have shunts, right? So shunts are where you have low VQ, right? So the alveoli are closed for business, right? There's inability to get inability to get air into the lungs or into the alveolus at all. Your perfusion might be great, right? But we've got all kinds of pus in there, or we have an effusion in there, or we have a pulmonary fibrosis that's going on. So the O2 and CO2 cannot exchange effectively, right? Or we have like bronchospasm where they're not getting air into the lungs at all, right? So the ventilation is reduced. And this one we can take it all the way down to 0 and like up top, right? Because you can't divide by 0, but you can divide into 0, or you want to word that, right? Because if I have 0 bread for my 10 kids, right? That's still 0 bread, right? But I can't have 10 breads and divide to 0 kids, or I don't know, I lost the analogy, right? But yeah, so you have a reduction in what, V or Q with shunts? With shunts, we have a reduction in the airflow or because of a pus or effusion or pneumothorax or bronchospasm, or they have ascites that's pushing up in the lungs. All these things are reducing ventilation, right? So normal VQ is what number? 0.8, right? So 0.8 and then, or 8 over 10, yeah. And then we are reducing the 8 or the 10. Yeah, so that's going to make it, instead of 8 tenths, it'll be 4 tenths or 1 tenth or 0 tenths. 0 tenths is 0. So it's 0.8 versus 0. So we have a low VQ, right? So again, 9.5 times out of 10, it's low VQ. Okay? And yeah, there's anatomic shunts where it's not a lung problem, right? So there's the lungs are fine. It's like there's nothing going on in the lungs, but there's what's called anatomic shunts. That's what you studied in like pediatrics, where they have like a VSD, a ventricular septal defect, or they have a patent foramen ovale or something. And adults do have PFOs as well. Okay, when we have strokes, they usually will do assess for PFO to see how'd the clot get to the brain. I thought clots go to the lungs, right? So about 20% of people don't have an open PFO, right? Where they have, or an atrial septal defect, where the blood just can go from the right side of the heart to the left side of the heart without even going to the lungs at all. Okay, so that's the blood bypasses the alveoli altogether. So there's such thing as an anatomic shunt, where you have a lack of flow, or it just bypasses the lungs altogether. And the one we're talking about now is a physiologic shunt, right? Where there's the lungs no worky, right? Alveoli is blocked, right? It is blocked with mucus, it's blocked with debris. Like our friend over here had a whole bunch of debris in his right lung, and we had to go with a bronchoscopy and take out the debris, and that will then improve the VQ, right? So he presented with what kind of VQ mismatch, low or high, if he has aspiration pneumonia. Yeah, low VQ, right? So you have atelectasis, or patients that are bedbound, they have high risk for atelectasis or ATX, right? Atelectasis is when your lungs kind of get sticky and they get more inflamed, and it's not quite pneumonia yet, but you can get fevers. And it's an atelectasis where your lungs are not aerating all the way, and that can lead to an issue, right? Lead to a low VQ, right? ARDS is our worst case scenario, which we'll talk about in much more detail when we talk about vents and vent management. But ARDS is full of fluid through not just one alveolus or two alveolus, but pretty much all alveolus, right? And with all that fluid from ARDS is filled in all of our lungs, that's a reduction in ventilation, almost all the way to 0, right? It's a really huge deduction in our amount of ventilation we can undertake, right? And our oxygen levels will obviously be a lot less because the oxygen can't get to the bloodstream.